So this is the index of the webinar right now. I will talk initially with a brief introduction about history, material, instrumentation of the arthroscopy. Then we move to 2 blocks. The first block will be lysis and lavage with the indications, some tips and tricks, some basic technique, and we will show a clinical case. Then we move to arthroscopic operative surgery, where some indications and some advanced techniques and a clinical case. And finally, we conclude with some take-home message. We know that the surgical options in the world right now in temporomandibular joint are divided in the first group, that is infiltration and arthrocentesis. This is a very effective and simple technique, blind technique, but very effective. And probably this is the most commonly done in the world with a low complication rate. Then we move to the arthroplasty or open surgery. That is a big also procedure that is used in many places in the world, wide indication, but of course, bigger morbidity. In more than 35% of all the cases in the world are probably open surgery with higher complication rates, of course. And finally, arthroscopy, we have very good results. It's a minimal invasive, have of course some difficulty in training, but probably less than 5% of all the procedures in the world right now are made of arthroscopy. So we should equal of these procedures and probably increase the number of arthroscopies that we are doing right now. We know that the surgical treatment in temporomandibular joint is increasing the minimal invasive surgery. And in this minimal invasive surgery, we know and we've seen a big interest in arthroscopy right now as respect of arthrocentesis that is getting low, and infiltrations, because we have very good results, we have is increasing. The arthroscopy was initially applied by Watanabe and Onishi in the 70s to our joint. Then there was an operative suturing techniques and so on by different authors that you already know in the 80s. Then we moved to a conservative because lysis and lavage, we saw that we have very good results. And then it was an explosion, but the incoming of the arthrocentesis with very good results and low morbidity. Right now, we know that we have a big interest in the arthroscopy. When we compare these 3 techniques and divide arthrocentesis, lysis and lavage, and operative, we see that lavage, for example, is done perfectly in the 3 ways, but lysis mobilization, for example, is bigger in operative than lysis and lavage arthrocentesis. Also, infiltration can be done in any of 3 procedures, but look at this. If we want to do something physical inside the joint, we have 2 operative arthroscopy. We can infiltrate, coagulate, biopsy, discopexy, and so on. So try always to go and to get to that step of operative arthroscopy. We know that the interest in the publication of arthrocentesis, as you can see, is increasing all this time from these initial years. And also arthroscopy, it was a great interest in 1989, and right now it's increasing again the interest in the publication of these techniques. So what are the pros of this technique, arthroscopy? We have a direct visual limb function, is the only way to do it. We have a maximum muscle relaxation because it's under general anesthesia. We can do visual diagnosis and palpation of the tissues. There's no other way to do it. We have wide indications. We can treat directly the pathology that we're seeing. Also, we have a very good legal document. Also, there is a placebo effect, very important, don't forget about it. It's an exclusive technique of us as usual or maxillofacial surgeon can be well remunerated with a low complications rate. On the other hand, of course, there are some cons of this technique, inconvenience, for example, the long training curve. We need some hospital facilities. We need a higher cost for the patient and the providers. We need expensive material. We need the assistant. We have some technical limitation, for example, the inferior articular space, the growing patients, that degenerative pathology, and also we have the lack of evidence-based studies. But remember that we are back after orthopedic and traumatology surgeons. They were really the stars of these techniques. But this technique is exclusive of oral maxillofacial surgeons. As we see in different areas that we treat and we deal, we see that temporomandibular joint is the only one that is not made by ENTs, plastic, or even traumatologists. But the others can be done by some others. So we must take care of this pathology and probably spread it worldwide, because we see right now the distribution of arthroscopy throughout the world is very inconstant. We have the first step, that is maybe Europe, Australia, and North America, where it's well developed. We have good training and good practice. We have a second block that is Asia. In Asia, we have very single centers that with a very high volume, for example, in China, some in Japan, and so on. And then we have the third one, that is South America, with a great interest. There are very few countries that they're starting with the technique, but of course we have Brazil, that they have a lot of experience there. And finally, Africa, there is similar anecdotal. How can we learn arthroscopy? Arthroscopy, we can do a theoretical learning that is done by papers, books, atlas, and so on. And also we have the practical learning, because this is the most difficult part to get. So we can do it probably in the future by virtual reality training, live-on courses, and so on. Our 3 steps are this one. Start taking a look at the orthopedic surgeons. You can learn a lot from them. Practice every endoscopic technique in our specialty, for example, fibroscopy, ENT, or endoscopic condylar fractures. Then the second one should be, the first step should be start practicing in some simulators. This is the first and the best designed by Dr. Florencio Monge here in Spain. It's very useful to have the first contact with them. Then you can move to the second step. The second step are the cadaver course. We have very good cadaver course. And although in this pandemic we have lost the direct contact between the professors and the assistant, we must return with this and start doing these practical courses in cadaver. That they are very useful. And the third step, of course, is to go on to some lift surgery. You can invite the professors, or you can go to any unit where you can see lift surgery with living patients, where you can feel really how is the technique and how they work.